Yeah, thanks a lot, Professor Merwert, for the invitation. It's really an honor to be invited and to give this lecture. We could decide the topic of our talk, and I would like to talk with you about innovations in cardiac implantable electronic device therapy. And I think in the next couple of years, the way we do cardiac pacing will be completely different to the way we did it the last years.
Ich verstehe leider nicht, was du mit Pacing
Fans
meinst.
Sorry, I have some problems with it.
It's saying it doesn't understand.
I cannot move to the next slide. Should I use the... Ne, es geht nicht. Okay. So when we look back, the first pacemaker was implanted in the 60s and the first defibrillator 1980, and also since this time the devices became much more sophisticated and became much smaller. There are still some two major remaining problems, and the problems related to conventional device therapy are pocket complications, as you all know, pocket hematoma after implantation, infection, erosion, and the lead complications like fracture, dislodgement, or endoplastitis. And when you look at the data, close to 10% of the patients get a pocket or lead complication within the first 5 years after implantation. And here I brought you a case of a patient. He was referred for lead extraction. Also, it is a rare case. We all hope we do not see patients with so many leads inside the human heart. What I would like to talk about today is the concept of leadless pacemakers, the concept of subcutaneous ICD, something which I think is very important. His bundle pacing, what can we do with this? And I would like to show you a short life-in-the-box case of a leadless pacemaker implantation. For me, when preparing this talk as well, it was interesting when looking in the literature that already 50 years ago a totally self-contained intracardiac pacemaker was developed. It was only used in the animal model, but when you look at the picture, it looks really very similar to the leadless pacemaker system we use today. Currently, 2 leadless pacemaker systems are available, one from the company Abbott or St. Jude, and one from Medtronic, the so-called microsystem. They are relatively similar in size. I think the major difference is the fixation mechanism. The system NanoStim from Abbott uses a screw-in helix, whereas the Micra from Medtronic is fixed with flexible tines. When we look at the data, how many leadless pacemakers were implanted around the world, the Micra already reached more than 50,000 implants since it came on the market. It's a little different with the NanoStim systems. They were only implanted close to 1,500. And the reason is that implantation of NanoStim was at the beginning stopped due to cardiac perforation, and then 2 years ago there was a recall of the battery, and up to now they did not come on the market again. What is the data regarding the performance of leadless pacemaker? There is a big study which was published in the New England Journal of Medicine 4 years ago. But it's very important, this is a prospective study, but it was a non-randomized study. And they included all patients with class 1 or class 2 based indication for cardiac pacing, and they had 2 primary endpoints. First, a safety endpoint, freedom from system-related or procedure-related major complications, and the efficiency endpoint. This was a combination of low and stable pacing capture threshold. And when you look at the data, and this was data collected over a period of 12 months, the pacing threshold was stable, the impedance was stable, and the R wave amplitude even improved over the time. As it was not a randomized study, you can only compare the patients with a historic transvenous pacemaker patient group. And when you look at the complication rate, what you found is short-term complications were a little higher in the leadless pacemaker system, and this was mainly related to some cases of cardiac perforation. and vascular complications, whereas the long-term complications were significantly reduced in the patient group with leadless pacemaker systems. I would like to show you very brief one of our live in the box, or one of our live cases of micro-implantation, and would like to show you how we proceed. I think it's similar with every procedure. Every hospital, every center has his certain steps and his certain routine how he's performing the procedures. How is the micro implanted? You have a micro delivery catheter and you have an introducer sheet. And the introducer sheet has a relative large diameter, and the outer diameter is 27 French. So what we do when we implant a micro, we start to give some contrast agent and look if the femoral vein is suitable for implantation of such a relatively large sheet. Next, what we do is a levography of the right ventricle. We do it in LAO and RAO. What we always want to do, we do not want to implant the micro in the apex. We always aim for the lower septum. And for us, it helps to get an idea by giving some contrast agent. And then the next step is, after placing the introducer sheet, you just bring the delivery sheet with the micro to the right ventricle. Here you see we are entering the right atrium. And here you see now we are lower septum, perhaps a little pointing to the apex. And now when we finally release the micro, we do something which is called the tuck test. The micro system is still connected to the delivery sheet with a little string, and you pull relatively strong to see if the tines are really stick to the right ventricle, and you can proceed with your procedure. And then finally we do like with a regular transvenous pacemaker, we measure electrical parameters, and then finally we retract the delivery sheet and the procedure is done. And it's a very, very fast procedure, around 20 or 25 minutes, and even faster than when you use when you implant a transvenous pacemaker. We call it set. I don't know the English expression.
It's just
the suture stick.
So we call it as a Z suture. We go under the sheet, and then we go up the sheet, and then again we go in the groin, and then we can like take both ends, and then you can make it like a Z, like a side suture. So and then when you do it, then you bring the tissue under the groin, which then brings up a pressure on it.
So we leave it for 6 or 8 hours, and it really helps a lot. So when talking about leadless pacemaker system, one problem and one question we have to discuss is, what is the end of life management of the leadless pacemaker system when the battery is empty? And I think 3 options are available. We can try to remove the non-functional leadless pacemaker and just implant a new leadless pacemaker. We can talk about adding an additional leadless pacemaker, or we can switch the system to a regular transvenous pacemaker. And when you look at the data, this is a picture 3 days after micro-implantation, and here it's probably relatively easy to retrieve the micro system, but when you look after 4 months, you see that there is a lot of fibrous tissue around the micro, which definitely makes extraction more difficult. When you extract a micro, there is no specific tool provided by the company, but you can use a snare as it is depicted here in this movie, and you can retract the micro system. And then you look at the data. This is a summary of some case reports dealing with the problems of retrieving leadless pacemaker systems. You see that both with the nanostem system and the micro system, retraction explantation was also possible after more than 1 year. I would like to show you one case in our hospital. It was an 84-year-old patient. he presented to the emergency department with symptomatic bradycardia, and when you look at the medical history, I think it's a typical patient for implantation of a leadless pacemaker. 1975 he got a transvenous two-chamber pacemaker, and then over the period of time he developed numerous pocket-related and lead-related complications, and finally in 2014 the transvenous pacemaker was extracted and a nanostem system implanted. And this patient unfortunately had this battery problem from Abbott, so he presented to us with a malfunction of the leadless pacemaker. Interrogation was not possible anymore, and we discussed with the patient what can we do now, and the patient said, well, I'm 84 years old and I don't want to have the risk of his extracting, and so finally we decided to add an additional leadless pacemaker, and as you see here, it's not a problem at all to add at least 2 or even 3 leadless pacemaker in the human right ventricle. So when talking about leadless pacemaker, we still have one major problem, and the major problem is it is only a one-chamber pacemaker. And when you look at the patient who got a Micra, these are mainly patients with bradycardia due to atrial fibrillation. And one problem the Micra cannot solve is that we have a lot of patients who actually need a two-chamber pacemaker. And when you look at the implantation data, it's around 14% of the patients who only get a single-chamber pacemaker, but the rest, 86%, actually need a dual-chamber pacemaker. And this is something which the Micra cannot do at the moment. And there is a very interesting study. It's a feasibility study which was published last year, and it is called the MARVEL study. And the idea behind was, is the accelerometer of the Micra able to measure atrial contraction? And if yes, you can use the Micra as dual chamber pacemaker. This is only a feasibility study, but what it is important, you do not need a special Micra. You can just download a new software to the pre-implanted Micra. And what the study showed, also it was only a feasibility study, that it is possible to use the accelerometer to measure atrial sensing, and this finally would allow us AV synchronous pacing and to implant a Micra also in patients who actually need a dual chamber pacemaker system. The next topic, which I think is really very exciting and I'm really very interested in it, is His bundle pacing. The way you reach the His when implanting a His bundle lead is normally from the right atrium, and on the right side you see a typical X-ray. And when you look at the EKG, and this is the EKG from the same patient, when you do a right ventricular stimulation, you get this very broad QRS complex. And when you are able to capture the His bundle, as you see on the right side, you have a really very, very narrow QRS complex. Currently, His bundle pacing is only possible with a system from Medtronic, but actually all other pacemaker companies are working on a system for His bundle pacing. And when you implant a His bundle lead with Medtronic, you can use a steerable sheet, this is depicted here, or you have a not steerable which is already preformed, and on the right side below you see the lead which is used for His bundle stimulation. And I think when talking about His bundle stimulation and which patients can need His bundle pacing, I think it has a potential use for patients who have a high right ventricular stimulation rate, and I think it can also be used for the classic patient with a left bundle branch block who need cardiac resynchronization therapy. And why is His bundle pacing perhaps superior to right ventricular pacing? And I think, as you all know, right ventricular pacing can induce cardiomyopathy, and there are a lot of studies regarding this topic, and these studies are the biggest which were published in Heart Rhythm, which investigated the incidence and the predictors of right ventricular pacing cardiomyopathy. And when you look at the data, you see that over the time, a significant portion of patients develop pacemaker-induced cardiomyopathy, and this depends on the stimulation rate, as you see on the right side. When the rate of right ventricular pacing is higher than 40%, you belong to a risk group, and that if it is lower than 40%, you still can develop pacemaker-induced cardiomyopathy, but the risk is lower. So this is one of our patients. This is 1.5 years after pacemaker implantation, and what you can see is significantly reduced left ventricular ejection fraction due to right ventricular pacing. And this is a picture, I hope I can start it. This is a picture 6 months after his bundle stimulation, and you see that the left ventricular ejection fraction nearly normalized. And when you look at the studies, is his bundle stimulation superior to right ventricular stimulation? You see these are relatively small studies, sometimes only including 10 or 20 patients, but all the studies you find regarding this topic clearly showed that his bundle pacing is superior to right ventricular pacing. The second group of patients which can benefit from his bundle pacing are the classic CRTT patients, highly reduced left ventricular ejection fraction and left bundle branch block. And at the beginning I was a little surprised and thought, why can his bundle pacing help patients with a left bundle branch block? But I think it's important to take into account that the fibers for the left and the right bundle branch are already predefined below the AV node. So for example, if you have a left bundle branch block which is relatively distal, you can reverse this left bundle branch block just by pacing distal of this left bundle branch block. And there are some other theories how you can induce remote electrical activation and finally overcome the left bundle branch block. I have to admit that data regarding his bundle pacing instead of CRT is relatively limited. You find a lot of studies which are not randomized, which are only a retrospective study, but there is one study which really compared directly in the same patient his bundle pacing with CRT stimulation, and what the study found is that with his bundle pacing you get a significant higher reduction in the width of the QRS complex. The left ventricular activation time is much better when you do his bundle pacing, and the left ventricular dysynchrony index is also improved with his bundle pacing compared to the classic CRT therapy. And the last topic I would like to address is the subcutaneous ICD. It's at the moment only available with Boston Scientific. And why this is important, I think everybody of you knows and has seen, and when you look at the data, is that patients with an ICD develop lead-related complications in a relatively high rate, and you see here after 5 or 6 years the first patients really begin to develop lead-related complications. And what is the advantage of the subcutaneous ICD? It is completely extrathoracic and extravascular, and you can avoid any problems related to the venous access. You can implant the micra without any fluoroscopic. You can just implant it looking at some anatomic landmarks, and also the SICD is significantly bigger. You can really get very, very nice cosmetic results for the patients. What is important to keep in mind that the subcutaneous ICD up to now can only deliver shock therapy. So no pacing is possible, and more important, no ATP delivery is possible. And we think it will change relatively soon, and Boston developed a system which is called modular cardiac rhythm management, and it is a combination of a leadless pacemaker and the subcutaneous ICD. And the idea behind this is that the subcutaneous pacemaker gets the information from the leadless ICD, can deliver both ATP and can deliver both antibradycardic pacing. They will start this study probably beginning of the next year. And when I summarize my talk, I think the device therapy already started to change, and I think the way we treat patients currently will definitely completely change in the next year. I think what is really getting more and more important is leadless pacing to avoid all the complications with the lead. Currently we can do only single leadless chamber pacemaker, but I think this will change in the near future. I think the subcutaneous ICD is a very, very good option, especially for young patients who do physical exercise. And I think the idea of physiological pacing to pace the hip spindle will become more and more important in the next years. Thanks a lot for your